Senator Cassidy, floor is yours.
Thank you, Chair Sanders, and hey, thank you all for joining us today. Incredibly important topic, really appreciate. I'm a physician. I worked in a hospital for the uninsured for 20 or 30 years. I've been at the bedside where I've had to tell someone they've got a terrible disease in which they may have hope, but nonetheless it's going to be tough, or maybe in some cases the diagnosis is more likely than not fatal. The last thing you want them to be concerned about is medical debt. That is a burden which they need not have. So we've got to address medical debt. But in medicine, we have a saying, don't just do something, think. We have to think about what is causing this. As you think about it, the medical debt is a symptom of a larger problem, the high cost of health care. What is driving that? If we address that, then we will kind of, along the way, address the issue of medical debt. Not entirely, substantially. Right now, Americans pay more for health insurance than ever before. On the Affordable Care Act exchanges, the average monthly unsubsidized insurance premium on a silver tier plan is $483 for a 40-year-old. For a family of four, the average unsubsidized is $1,600 per month. And the average deductible is $5,000. So this is the amount that the patient is paying before they benefit from the plan. So this kind of coverage is oftentimes unaffordable, and this is what can lead to medical debt. We have to examine where patients are taking on this debt. Data shows that hospitals are responsible for more than half of medical debt. That's important. Congress has long provided additional resources and support to hospitals to help cover the cost of a patient who may otherwise be unable to pay. Many federal grant programs are available to hospitals in financial distress to ensure that they they should be able to continue to be helpful to those who are unable to pay. One example of this is the 340B program, where hospitals are able to bill full rate for a drug which they acquire at a sharply discounted amount. And the idea is that they would use that delta, that profit, if you will, to help the patient. But there's other examples too. The disproportionate share program, or sometimes the upper payment limit program, as well as a nonprofit and tax-exempt status for many hospitals. There are a lot of resources out there for that 50% of the medical debt, which is contributing to the problems that the chair just spoke to. Speaking specifically about 340B, hospitals participating in 340B get substantial discounts on prescription and oncology drugs, but it is unclear if these discounts are actually being passed to patients. Since last year, I've led an investigation in how different healthcare entities are using this 340B revenue. The chair has declined to participate, but it's an important topic to consider if we're going to address both a root cause of medical debt and two, why are the things that we're putting out there that may potentially address this not addressing it? If we just put in one more program which is poorly implemented, we're going to be back in this hearing 5 years from now. We've got to see how the ones we've already done are actually working. Don't just do something, think. So I'll also point out that it's been proposed that we just cancel all medical debt. My colleagues on the other side of the aisle suggested that. But to be clear, a one-time cancellation of medical debt is not a solution. It is a Band-Aid approach for a one-time problem that's going to come back. Don't just do something, think. It also shifts the debt upon taxpayers and upon those who, we think it's free. It's not free. If people haven't noticed, we've got this incredible debt and deficit in our country. And that's going to weigh upon our children and our grandchildren, upon these young interns who are here. What about our obligation to them? Don't just do something, think. Well, may hear today about Medicare for All, it's been mentioned, but I'll also say that a healthcare system in which you think it's free because the taxpayer is footing the bill, you've never seen how expensive something can be until you perceive that it is free. This committee has a long history of engaging in real bipartisan efforts to ensure that our healthcare system works better for patients. Just last year, the committee passed the PBM Reform Act to address malaligned incentives affecting PBMs and the price patients pay for the prescriptions, we need that signed into law. That would be a way to begin to lower the costs for patients. There's other examples too. I look forward to exploring them. I thank you all for being here. You represent a spectrum, but this country is a spectrum. And so ideally, we're going to learn from you the kind of width and breadth and depth of that which we can do as a government to help reduce medical debt for all Americans. Thank you. I yield.